Hello, everyone. Greetings. My name is Professor Marc Russo. I am an Australian pain researcher and pain clinician, and it's my great honour to be invited to give this talk at Crash Conference 2023, which is on early management of complex regional pain syndrome. I hope I can adapt it for your circumstances that you're treating on the ground there in Ukraine. And I do hope that this talk will be of help to you in that process of caring for patients. So what I'll do now is share my screen and commence the talk. And hopefully you can now see my actual screen and slides. So, and my disclosures are nil for this particular talk. So what are the demographics for complex regional pain syndrome? Typically in civilian life, when we talk about it occurring after trauma or after surgery on the peripheral limbs, the incidence for hand and leg surgery typically is somewhere between 1 in 100 to 1 in 200 patients. However, we don't really have strong data collected prospectively in war zones. So there's very limited data available to us, but you would think that it would be higher than that because of the number of high velocity ballistic injuries that occur in war zones. But one data point we do have is from Steve Cohen and his team in the United States, and they looked at the number of patients being treated from Operation Iraqi Freedom back in pain clinics, military pain clinics in the United States, and approximately 1 in 25 patients they saw had complex regional pain syndrome after a battlefield injury. We do know that obviously with transection of nerves that there's a much higher incidence in the military setting of complex regional pain syndrome type 2, i.e. with nerve injury, than there is of complex regional pain syndrome type 1, i.e. in the absence of overt nerve injury. So the diagnosis. Typically, unfortunately, the diagnosis is made late. It's typically made 2.5 years after the symptoms have initially been present. And that obviously means that if it's been diagnosed after 12 months, that the condition becomes chronic, because really the opportunity to extinguish this disease is in the first 12 months of symptom presentation, when curative treatments can be available. So it is assumed that the earlier the diagnosis we have, the earlier is the treatment. And certainly if we look at things like abnormal nerve pain after knee arthroscopy, for example, we can do a simple lumbar sympathectomy with local anesthetic in somebody who presents with abnormal knee pain after a knee operation. And typically you can have that completely resolved with a single local anesthetic injection alone, not requiring multimodal treatment. So the way to come to the diagnosis, of course, is to use the Budapest criteria, and you can look that up and make sure that you're using that in your diagnostic process. But of course, what we're looking for there is the presence of symptoms and the presence of signs of the autonomic changes associated with CRPS. And that is color change, swelling change, sweating change, and heat change, so cooling or heating of the limb. And what we need to know is that that really is only present over the first 3 to 9 months. It typically fades over time. So that's why documentation of whether these symptoms are present in the first 12 months is vital in terms of making the diagnosis. Because once they have faded, then what you're left with is weird, unresponsive neuropathic pain, and one can miss the fact that this is actually CRPS. So the best way to get that early diagnosis is to say, if you see a patient with intense pain that's unresponsive to your standard measures for treating that pain, and they have some autonomic symptoms and signs at 1 month, this is probably CRPS in evolution. And the earlier we can jump on this, the better. So let's always keep that in the back of our mind. Intense pain that is unresponsive to standard measures plus autonomic signs at 1 month or more equals CRPS. So how are we going to pick that up? We really can't rely on the individual clinician to pick that up because we know clinicians are variable in their skill base and their knowledge base. So we really need a structure in the healthcare system to detect and deal with these outlier patients. And so, number one, we need to educate the treating teams to its existence. So medical education for physicians and first responders is paramount. We need to have a surveillance program to detect it. And then you need a central registry of cases so that you can audit your outcomes. You can rapidly apply innovative treatments if you need to, or if you're restricted in what treatments you have available to you. And you can follow out the cases longitudinally so you know what happens long term to the patients. Do they get better? Do they not get better? And obviously, somebody must be allocated the responsibility for treating the condition. So it may be that you have one dedicated centre in all of the country responsible for treating these particular patients with CRPS, or you might have 5 centres, or you might have 10 centres, but you probably don't want 100 centres where each person sees one case every 5 years. That is not going to be helpful for high quality results and getting people back to activities or soldiers back to their duties. Now, and obviously all that costs money and needs to be calculated into the equation. So a hypothesis that you could put together is that early treatment of combat CRPS needs to be a little bit different to the way we treat civilian CRPS. And the reason I say that is probably these 5 things that have particular importance in relation to combat-induced CRPS. And that is, in number one, these patients probably might have multiple things wrong with them, orthopedically, or in terms of peripheral nerve injury. And in that particular setting, the CRPS takes a more chronic course if they have to have 5 operations over 2 years to address these. It is far better to surgically fix everything that you can as soon as possible so that you've completed the surgical operations and then can get the patient into the rehabilitation phase. Point 2 is that we must aggressively rehabilitate the patient. There probably isn't the healthcare resources to treat these patients long term. And so we want to use aggressive physical rehabilitation, aggressive weight loading, aggressive use of the upper limb, and that includes a fairly standard physical therapy technique now, which is motor imagery therapy. In particular, if we see that the patient has a negative attitude, has anxiety, has depression, has a lot of catastrophizing about what's going on, or they have a non-willingness to use the limb, we want to get a psychologist involved to help change their cognitive framework around their pain and around the need to use their limb. If they don't use it, their CRPS is essentially going to become chronic. In particular, for combat, there's a higher incidence of PTSD, post-traumatic stress disorder, than there is in the civilian cases. And so that needs to be aggressively treated, again, with cognitive behavioral therapy with a psychologist, but also by using drugs that help switch off the noradrenaline and adrenaline surges from the brain and from the adrenal glands. So that's using clonidine at nighttime, using prazosin at nighttime to ablate nightmares, improve sleep, and treat the PTSD symptoms. And in particular, we want to ensure restorative sleep. So that obviously means a safe environment, and it means all the sleep hygiene techniques that allow restorative sleep. So they are the particular features for combat CRPS. Obviously, in addition, that isn't the only treatment. That's the backbone or the basis of treatment. But in addition, we'll typically use oral corticosteroid to reverse the inflammation of the nerves, typically for 4 to 6 weeks. And there are different dosing regimes that are used, but they all circle around 25 to 50 milligrams per day of prednisone or prednisolone for 4 to 6 weeks, either cutting off or followed by a 2-week taper down to 0. Primarily, as fast as possible, we want to avoid conventional or pure mu opioids because the limited evidence we have is it makes the condition worse. It causes opioid-induced hyperalgesia in a condition that is marked by the presence of hyperalgesia. So that makes things worse. So where possible, we want to remove the opioids from the patient. If there is surface hypersensitivity, what we call skin allodynia, then a topical lignocaine or lidocaine patch, one trade name is Versatis patch, is very useful for ablating that hypersensitivity. And in particular, we'll use sympathetic blocks in acute cases. There's an example of sympathetic blocks at 3 levels being performed, L2, L3, L4. Typically around the knee, we need to block L2. Typically around the foot, we need to block L3, plus or minus an extra level. And not only can we do blocks, we can also inject botulinum toxin, 100 international units, or we can do pulsed radiofrequency neurotomy of the sympathetic chain through an RF needle. So there are different ways to do it, but it's really important to get that in and to shut down the autonomic hyperactivity. And in research that we've done at our research unit and amongst extracted from the literature, it seems some things are useful which appear to actually slow down some of the immune activation in terms of activation of dendritic cells and macrophages, which are probably at the heart of this, because we now understand it to be an immunoneurological disorder. And that is aspirin, 300 milligrams 3 times a day, vitamin D, quite a large dose, 200,000 international units as a stat dose, vitamin C, 500 milligrams per day, and curcumin. So we use that as a combination in our practice, and we've had numbers of cases of CRPS that have resolved with that alone as the sole treatment. Now, after we've done that and the patient still has symptoms, we start to move into non-evidence-based second-level treatment or rescue treatment. And that may be if we think there's inflammation of peripheral nerves due to trauma, fibrosis, nerve injury, we may inject under ultrasound platelet-rich plasma around the nerve, not in the nerve, obviously, but around the nerve sheath. And that can decrease pain because there's additional pain from an inflammatory component. Certainly, if there's depression and anxiety, we'll start an antidepressant, and we typically use duloxetine for that because it's also an oral antineuropathic agent, and it decreases central sensitization. Another treatment that we use, but it is non-evidence-based, is to put a RF electrode next to the dorsal root ganglia and cover off, say, 3 DRGs, 3 levels, and do pulsed radiofrequency neurotomy. So 70 volts pulsing at 42 degrees for 4 minutes for each DRG level. And we may use lignocaine infusions or ketamine infusions for 5 to 7 days. Typically, lignocaine is 2 milligrams per minute. Ketamine starts at 5 milligrams per hour and slowly increased over a number of days to 40 milligrams per hour intravenously. Now, I just want to raise this issue because this is a very expanding and new area that we're looking into, which is the role of zinc. We have one paper from 2012 that showed that one analyzes the gene proteomics of patients with CRPS. It was found that they had a metallothionein deficiency in the peripheral nerves. Now, metallothionein is a zinc-based protein. So there was a deficiency of zinc for this particular protein construct. And this was not present in patients of a control nature. And we know that critically injured patients who come into trauma ICUs have a very high incidence of having a deficiency in total body zinc. The incidence, in fact, of having a low zinc 1 month after your ICU is 98% of all patients. So that is everyone. And we think, as a hypothesis, that zinc deficiency may be one of the drivers, along with immune activation, in complex regional pain syndrome. So where possible, please measure the zinc level If your zinc level is low, supplement with oral zinc, which is cheap, 50 milligrams 3 times a day. We are increasingly seeing that something like 80% of the patients with CRPS who present to our clinic are in fact zinc deficient, and that's in a civilian setting. The role for intravenous zinc is not clear. May be useful, may be unnecessary. So in summary, please try and look at an institutionalized, systematic approach to capturing the patients who have these symptoms. Remember, intense pain that's out of all proportion, that is unresponsive to standard measures, that at 1 month has autonomic symptoms and signs associated with it. The limb is cold, it's warm, it's swollen, it's hypersensitive, it's sweating, etc. Have a systematic approach to both diagnosis and recording and documentation of cases and treatment. Aggressive rehabilitation and treatment. These patients must weight bear. They must use their limb. The classic 1987 paper by the hand surgeon from America, Kirkedy Wallace, was related to scrub and carry. That is, carrying a briefcase filled with increasing weight in the briefcase and carrying it for half an hour several times a day. That was the carry for upper limb. And scrub, actually getting on the floor with a scrubbing brush and making circular motions with the hand. So it's a pressure-based work, was the original scrub and carry. And that still has quite a lot of validity today in terms of getting the patients better, along with the graded motor imagery program. That's the modern physiotherapy technique. And at the end of the day, in your clinic, if you are treating large numbers of these cases, you need a multimodal care approach. You need a team. You need a pain doctor. You need a psychologist. You need a physiotherapist. You need an occupational therapist. So you need to try and put those people together in your team to treat these patients. That's a quick run through. I hope that's been helpful. And I hope if all's working well with the Zoom link, shortly I'll be online to answer questions in person via the Zoom. So thank you very much for listening. And I'll stop sharing my screen and pause the recording.